Alrighty, so it's 10 o'clock and I think we will start the Calgary ED COVID rounds update. I'd like to welcome you all to join us again for update number 6. And I'm just going to introduce Dr. Eddie Lang, our academic and department head. And Eddie, for your leadership update.
Thanks so much, Stuart, and congratulations to the presenters and all the folks that are helping us out on this effort, and really excited about the lineup that's been coming together for this COVID update. So we're approaching the 2-month mark of the COVID pandemic, and I want to kind of give a high-level overview. It's really building on the content that was in my notes from Eddie's submission to the newsletter just a few days ago. But I think we're reached a point maybe where we need to look at a different approach or a different phase to what we're doing and think of it more in a maintenance capacity. Can I have the next slide, please? So I'm just going to quickly cover 3 big topics. Where we are at this point in time at the end of April in the pandemic, some information on staff safety, and then, this has been such an incredible transformation for our department, for the Calgary zone. It would seem a shame if we didn't leverage or take advantage of the things of the innovation, of the things that have come together, including virtual rounds, and think of how that's going to shape the future of emergency medicine in Calgary. Next slide. So you may have seen this. This is the latest modeling update presented 2 days ago by Alberta Health, presenting both low, probable, and elevated scenarios in terms of hospitalizations. And those white bars at the bottom represent where we are actually at in terms of hospitalizations in the province, just under 80 total. And even these models are significantly reduced from where we were at the April 5th modeling. So this is really good news in terms of the impact of the COVID pandemic on acute care, but of course it's still a very difficult and stressful situation to be in, with all of us experiencing loss and challenges from a variety of perspectives. Next slide, please. This is some more detailed data on Calgary zone, which is updated daily through the Alberta Health website. And at the present time, we are sitting at 59 hospitalizations in Calgary. That's the orange bars. You see a slow, gradual uptick. That was at 40 at the beginning of the month, and is something we're certainly keeping an eye on. That's patients admitted to hospital with confirmed COVID, either managing pneumonia or sometimes admitted for social reasons because it might be the only way to safely isolate them. Remarkably, the ICU load has been quite stable, sitting at 16 patients in the ICU, most vented, but not all, and that's hovered around the 16 to 20 mark since the beginning of the month. Next slide. Another interesting way to look at this is how the hospitalizations look from a population perspective. So this is a graph. The red line is Calgary, showing how many individuals per million are coming into hospital roughly every day. And this has varied between 1.5 in late March up until 3.5 most recently. And so that's per million population. We see a lot of the uptick being related to the outbreaks occurring in South Zone and also in Calgary Zone related to the meatpacking plant. Next slide. So what I think some of those data are telling us is that we are probably looking at, those are all COVID-related admissions. Thanks, Sean. What we're looking at is that we are probably grumbling along there's a big debate within HS as to whether we've actually reached a peak and are now in a maintenance phase, or there still may be a modest peak coming later this month. In any event, I think most thoughts are turning now towards what the impact of reopening will be. And the government released their plan to at least begin with getting at the backlog of elective surgeries or scheduled surgeries, and that's going to certainly be a step in the right direction. And we'll, of course, be very vigilant in monitoring, as is essential to our role in emergency medicine, as to how things are going to play out as opening continues. I want to talk about something that, of course, was very much on our minds and still is, of course, on the staff safety issue. What we have seen, this is from Verna Yu's update a couple of days ago, is that there are 137 HS staff who've tested positive out of 15,000 who have undergone testing. That's just under 1%, roughly similar to the population level of positivity. And only 10% of these 137, thankfully, are known to be workplace exposures. The rest are under investigation. Almost 1,000 physicians have been tested in HS. 22 are positive, but none of these, although a couple are still under investigation, none of these have been deemed to be through workplace exposure. And this really tells us that the PPE is working and is working well to protect ourselves and our colleagues. Last slide. Or that second last slide. One of the things we're following closely is how this COVID situation has impacted our operations. And everyone's undoubtedly aware that our volumes are down significantly. They're down total of 32% reduced visits since the pandemic started. And that's a little bit less than the 36% drop that we noted a couple of weeks ago. But what is also very intriguing, and we're working avidly to understand, is why are there 1,600 fewer admissions since the pandemic started? That's 22% decrease. I mean, some of it is delayed presentations, and we're seeing people come in sicker, but there may well be other things going on, and we'll have more updates on that later. But of course, what this has translated into is a remarkable improvement in the typical metrics that we use for ED operations. So everything is better. We're hardly boarding at all. Our EMS offload is down, and as our wait times and are left without being seen. And hopefully we can capture some of these improvements and maintain them in the post-pandemic phase. Last slide, this is the last slide. I'll pass it on. So what is the new normal going to look like? Because the virus will be with us for a while, and things have changed in ways that may be with us for many, many months to come. I can't capture it here in the short time that we have, but one thing I would suggest you do, if you have an opportunity, haven't already done it, is to visit the CAPE website, look at the April 22nd town hall. Dr. Michael Schull, colleague from Sunnybrook in Toronto and CEO of the Institute for Clinical and Evaluative Sciences, at about the 45-minute mark of that presentation, does a really thoughtful and careful evaluation of what COVID will mean for us going forward. And the basic message is we need to seize the day, take advantage of the innovations and the incredible collaborations that have emerged during this period, and carry them into the future. Thanks very much, Stuart. Thanks, everybody, and we're looking forward to the next presentations.
Excellent. Thank you very much, Eddie. And as usual, thank you from our group to the leadership and all the great work you guys are doing for us. We really appreciate it. So moving on to the agenda, we just had the leadership update from Eddie. We are now going to jump into the clinical component, which is COVID pearls lessons from the last 8 weeks. And that's going to be part of simulation lessons, airway lessons, and PPE. And Huma is going to do the wellness update. Sean will do the Q&A, and then we'll wrap it up. Just a reminder again about the Q&A. If you have a question, please post it in the Q&A section, not in the chat box. And before you post your question, check and see that somebody hasn't already posted it, because if they have, you can just hit the like button, and then that will move it up in for Sean's attention. Okay, next slide, please. So I'm going to start the clinical component by presenting pearls from COVID simulations on behalf of the Calgary ED staff simulation program. As you know, we've been doing a lot of simulation in the last 6.5 weeks. And so these are some of the lessons that we have learned. They are not specific to intubation, because Brian is going to get more granular about that in the next section. Next slide, please, Aaron. So first of all, I'd like to thank everybody, all our staff, for taking part in SIM. Since March 17th, there have been 301 physicians have gone through the simulation. It's been a fantastic job done by Gord and the ED staff simulation program to upscale from the already incredible staff simulation program. But this has had significant impacts on what we've been able to achieve. And I'd just like to thank you all for being part of that. Next slide, please, Aaron. So what did we learn from SIM? We learned that knowledge translation is really challenging when there's so much new information coming at us. We've learned that there's wide practice variation amongst our ED physicians. And while practice variation is inevitable and every patient encounter is different, the variation in practice can lead to some confusion amongst team members who themselves may be struggling to work out what the recommended practice is and how that impacts their roles. So ultimately, this confusion could lead to poor team function, poor patient outcome, and to strained team dynamics. So as we go forward, what we'd like to ask you is just to be aware of the suggested process in Calgary for managing critically ill COVID patients, as we hope that's going to improve the outcomes. And if you choose alternate patient management strategies, at least acknowledge the ED recommendations to the team and then explain to them why you are maybe moving away from those recommendations, just so that keeps everybody on the same page. Next slide, please, Aaron. What we also learned, though, was that we are open to different ways of trying to translate the knowledge that's coming at us so quickly. And this bar graph is a representation of the YouTube hits on the update number 2, where Brian discusses intubation on the day before one of the simulation days. So this information that was a reminder was sent out to the group. And as you can see there was a significant upswing. The little dotted line is 25 people. And so probably everybody who got the email reminder looked at this YouTube video. So we are open to different ways of trying to interpret this knowledge. With that in mind, and as we'll be managing COVID patients for quite the foreseeable future, the working group has created a cheat sheet with the help of Sean and the Calgary ED staff simulation program that you can use, and that will be available with these notes and in the newsletter. Please remember that things are changing so quickly, so keep that in mind when you use this, but it could be used as a framework for you to create a detailed approach to the COVID patient in Calgary. Next slide, please. I'm going to try and frame this as what is different to our normal practice, because we are very good at what we do. We are very good at resuscitating people, but there are some tweaks and changes that are specific to this COVID time. Pre-briefing has always been critical, and it comes up time and time again, both in info and in simulation, as to how helpful it is to the team dynamic and to the team function. But it's perhaps even more important now when you're in a small room and you can't go backwards and forwards. Know your roles if you are the support physician, if you are the primary physician, because once you're in the room, you can't move out. So the second physician could be a cognitive offload if you have a medical problem, that you could just ask that physician to take over and manage completely. Know your difficult airway contents and where it's stored. Please, next slide, please, Aaron. We are resuscitating in different areas. The rooms are small. Please think that through as to what that would look like for you and your team once you get into the room. With that comes communication challenges, and this was a regular theme for all the process simulation that we did. Each site has different challenges, and so please be aware of what the processes are at the sites that you work at and how to work around them. Go and look at them and see how they might look. It's challenging to communicate through a closed door, but the door can be kept open until the AGMP begins, and the physician can change position. You can move towards the door so that when you're communicating with the people outside the room and inside the room. Now, each site is going to be different. Foothills with the anteroom might be different, but please work out the best communication strategy at your sites. Next slide, please, Aaron. Giving orders and the people in the room are now different. So give orders to the right nurse. Medications need to be drawn up by the nurse outside. So consider that different positioning where you might be at the door and you can talk to the nurse outside with the meds. Also be specific about medications and doses that you need, so it reduces the amount of time that people will have to spend going backwards and forwards. We're now in small teams in small rooms, and that can impact the whole team. You may need to do different things to what you may have done in the big resus bay. There's only one RT, and so as a physician, you may need to take on some of those roles, for example, holding the BVM mask, or perhaps knowing how to push some medications, knowing how to be comfortable with working the Lucas CPR device. Please be aware that you may need to help and be aware of how to do that. If you are going to do an AGMP, consider putting up a sign so that the rest of the department knows. Next slide, please. There are relatively minor changes for ACLS and COVID patients. One of the most important is to anticipate that if you think you'll be doing an aerosol generating medical procedure, so CPR or intubation, then be in your full PPE with an N95 when you go into the room, so that you don't have to leave the room and change during the process. We're moving back to ABCs rather than CABCs, and you may pause CPR during intubation. Anesthesia is available and should be used when needed. So this is important in that when they come down, anesthesia requested that you be specific as to why you want them involved and what you want them to do in the room. If you do move to front of neck access, please be specific about what you're asking for and what your technique will be, because asking for a cric kit is not helpful given that there's so many different people's ideas of what cric means. So please be specific. And then the final point is please remember to debrief. There've been lots of really good debriefings after these events, and there's been great learning, but it also creates an opportunity for staff to support each other and to come together in these really challenging times. And so with that, I'm going to wrap up the learnings from simulation and hand over to Brian to get into a more granular look at intubation. Brian?
Hey everybody, so thanks Stuart for that update from our sim group, and thank you also for keeping us on track as the working group, providing some of these weekly updates. So we thought it'd be helpful at this time to take an opportunity. We're actually going to show a majority of the video that was shot here in Calgary showing the airway management for a COVID positive patient. So we're going to go through this video. Some of you have seen it, but I'm also going to be adding in some additional kind of narrative concepts in the background as we go through it. And so here it is. So first and foremost, you have a COVID positive patient in respiratory distress and you know they're coming in. You know, it's important at this time to take the opportunity to prepare your team, perform the STOP pre-entry checklist, and make sure the items are discussed. With attention to detail on pre-oxygenation, your intubation plan, your exit, and your emergency strategy. Once you've discussed your plan, you're going to head into the room together. It's encouraged to have the patient sitting up to maximize their FRC, allow a position of comfort for them, place nasal cannula on the patient with a preference for the green high flow nasal cannula, and I'll discuss later. You have more time than you think for oxygenation here. So be deliberate in allowing some comfort in those positions. Here you can see our RT is checking the connections on the circuit. This is to prevent inadvertent disconnection during airway management. All sites have this circuit pre-assembled and ready to go. This is what it looks like, and it includes a viral and a heat and moisture exchange filter. Use enough oxygen flow rate from the wall so that the bag is fully inflated, so that after the patient takes a breath, it stays fully inflated. The patient must have enough inspiratory force to open the valve in the BVM. We really encourage the use of a BVM PEEP valve and this setup for pre-oxygenation. We call this passive oxygenation. Is much more effective with that PEEP valve than just a non-rebreather mask. Ensure a good seal and comfort for the awake patient. You'll only have to assist with squeezing the bag if the patient is apneic inappropriately ventilating, or severely hypoxemic. Use your judgment. This does have the potential to be an AGMP, but you're prepared for that. There's no rush. Allow lots of time for pre-oxygenation. We really want you to use the airway management pause. It now has specific considerations for COVID patients built in. This gives you additional time and cognitive reminders to 1, oxygenate as best as possible, 2, discuss your plan, and 3, double check your equipment and your process. When you and your team are ready, proceed with predetermined doses of your induction agent and paralytic. Wait for full paralysis. Have the patients, despite the oxygenation status, because full paralysis will facilitate better views and easier passage of the tube. Remember that slow is smooth and smooth is fast. As the patient becomes apneic and paralyzed, you can do a more aggressive 2-handed mask seal and jaw thrust, demonstrated by Dr. Lee here in the video. Really open the airway and facilitate oxygenation during this apneic period. We very much encourage the use of this VE grip. It's more effective and it's less tiring. An example is shown there. For most of these patients, there's a strong preference for video laryngoscopy. It allows you to create distance between yourself and the patient. It protects you and the team by minimizing exposure, and it creates situational awareness for the whole team. If the patient desaturates, it's okay to use to bag and use a 2-hand, 2-person technique. This is a good example demonstrated by Dr. Lee. At this time, think of your exit strategy, but as long as you're oxygenating and you have time, call for extra help or resources. And if at any point you can no longer oxygenate, move towards an emergency strategy. We can stop the video there. So I encourage everyone, if you want to take a slower look through there, it's important to continue to build the mental model of what airway management looks like for the patient so that the team and can function well and the patient has the best possible outcome. We're just going to do a few slides to kind of highlight some of the important points. So go ahead, next slide there, Aaron. This is a reminder that the COVID airway management best practice considerations is available on the website. A very useful tool that's put out in conjunction with RT and ICU. A very important tool to be able to walk through it maybe on a regular basis or pre-shift. Next slide. I'd also encourage everyone to look at the airway management pause. Again, useful as a tool to cognitively go through ahead of time from time to time and in the moment, given some of the COVID-19 specific considerations that you see. New paragraph. Next slide, please. From an oxygenation perspective, COVID patients have significant oxygen needs. Take the time to titrate to their needs. If they come in on a non-rebreather mask with EMS, take the time to put them on some nasal cannula, titrate, and see what their actual needs are. As mentioned, the decision for intubation and positive ventilation is not based solely on flow rates. A wide range of clinical factors will go into this decision. Next slide. Nasal cannula are very comfortable for these patients and a good choice for oxygenation. We have regular nasal cannula and high flow nasal cannula. Sometimes the terminology can be confusing. The high flow nasal cannula are still dry oxygen delivery from the wall. They have green tubing and they just allow more laminar flow and they're a little bit more comfortable in those higher flow rates. Usually above 6 liters, your RTs will switch out your nasal cannula for these green tubing versions. You can titrate those flow rates up to 15 liters a minute, and they're very well tolerated. If necessary, you might consider use of a non-rebreather mask over top of this setup as well. Next slide. For spontaneous, now we're going to move over from general oxygenation and supporting these patients to pre-oxygenation in anticipation of RSI. So for spontaneously breathing and compliant patients with adequate ventilation, you can see what we did there in the video. You want to optimize positioning. You want to use those high flow nasal cannula underneath the face mask with a PEEP valve and a BDM. We call this passive oxygenation. You're going to minimize leak to maintain that PEEP and spend lots of time in your pre-oxygenation strategy. New slide. Next slide. This is an example of what it looks like with our pre-assembled circuit. Again, you're directing your attention to just maintaining a good seal with a good two-handed technique. You can see the viral filters in place, and then making sure that your flow rates are high enough so that bag inflates with patient's breath, with each patient breath. And also to remember that the patient has to generate enough inspiratory force to open the valves in this device for this to work effectively. Next slide. If patients are inadequately oxygenating during this period, due to apnea or just ineffective respirations, you can consider positive pressure ventilation and squeezing the bag. It's important to do this with careful timing during the patient inspiration to prevent any mismatch. The best provider who's skilled in doing this would be a good choice to avoid any leak or gastric insufflation. Another situation could be that patients are agitated due to their hypoxemia and might not be compliant with this pre-oxygenation. We would consider medications such as ketamine in small doses to encourage compliance. This is a delayed sequence intubation type approach and should allow some passive oxygenation that we've described before, as long as the patient maintains their respiratory drive. Any squeezing of the bag, make sure that you go slow and you keep your pressures low, as this can be potentially an AGMP. Next slide. The preference for video laryngoscopy comes from the fact that you can create space between you and the patient. It can protect you and the healthcare team from exposure, and it brings situational awareness for the entire team. But very specifically, it also brings together that RT-MD team to work together to facilitate a quick and effective delivery of that tube and subsequent ventilation. Ideally, in your hands, this is faster than direct laryngoscopy. New paragraph, new slide, please. So this is a great example from Dr. Lee showing keeping space between you and the patient, and good posture and intubating technique. New paragraph. New slide. From a reoxygenation perspective, your initial optimized approach is unsuccessful. At this point, you should be calling for anesthesia if you haven't already mobilized resources. We talk about critical hypoxemia. Again, use your judgment. In the best practice considerations, we talk about SATs less than 70%. If you need to reoxygenate these patients after an initial unsuccessful attempt, two-person, two-handed BVM ventilations, keeping your breaths slow and your pressures low, and try and minimize your leak as much as possible. Next slide. This is again what it looks like with a good two-handed mask seal. And then having that RT squeeze the bag is necessary. Next slide. Your exit strategy, first and foremost, should always be to fall back to optimal, the two-handed, two-person BVM with best seal. If that's successful, then you have time to continue to continue with other decision making. An exit strategy may also include an iGel or some other second or third generation LMA. We should recommend here that there's been some evidence that if your first choice doesn't work, there's a second option that might. And we have two options, both the iGel and the LMA Fast Track, readily available on your DEM cart. Remember that as long as you're oxygenating the patient, you have time to consider getting help or other strategies that will make this process safer for the patient. Next slide. This is what their iGel looks like, and on the other side of the screen, you'll see the Fast Track LMA, and this is what's available on the DEM card. So if you don't have that much exposure to it, please have a look at it so that you know are familiar with its use. Next slide. Question that we've got fairly frequently is if patients, more so if patients are coming in to the department with a supraglottic airway. Again, most commonly, that's going to be a King LT with EMS. And the question is whether or not whether or under what circumstances we should be switching these out to a secure endotracheal tube in COVID positive patients. My answer to that is that you need to perform a bit of a risk analysis and ask yourself a few questions. Were they difficult to intubate, and that's why the King LT was placed? Are there anatomic features of difficulty? Has there been significant trauma to the airway now because of the attempt or because of the supraglottic insertion? How long has it been in place? There are case reports of them being in place for quite some significant number of hours and having a lot of airway swelling and edema. Is there significant leak, or is the supraglottic working well? And then finally, what are your oxygen needs, your pressures of ventilation, and your clinical status? If all of these factors kind of lead to a low risk situation, then I think it's better for the patient and for the team from a safety perspective to have a secure endotracheal tube placed, and you should feel comfortable removing that supraglottic and proceeding with an endotracheal tube as we've described in an RSI type approach. If it's a very high risk situation because of some of the answers to these questions, then I think it's perfectly reasonable to oxygenate the patient safely, protect yourself from AGMP, and initiate consultation for a change in either an OR or ICU involvement in conjunction with our anesthesia colleagues. Next slide. Finally, if at any point during any of this management, we get to the point of being unable to oxygenate despite optimized attempts, again, quickly, an attempt at a supraglottic could be made if it hasn't already been done, but otherwise we should proceed rapidly to a surgical airway or front of neck access. Again, preference for a bougie assisted approach. However, be specific in what you're asking for and be specific in what your plan is going to be. Next slide. I'm just going to take a real quick look at some questions here. I don't see them obviously here, so we'll pass it on to Catherine for our PP update and lessons learned, and hopefully we can address some questions later.
Thank you, Brian, and thanks everyone for tuning in. And again, thank you to Stuart and the group for organizing these weekly updates. I only have a few brief PPE updates. Next slide, please. The first would be just touching on some of these new surgical masks that we have. They're called Vanch masks. They're a bit of a darker shade of blue than what you're used to with the Primagard or Pri-Med masks. There have been some concerns about the fit of the mask, and AHS has come out with some recommendations about how to improve the fit of these masks. If you are having issues beyond the fit of these masks, I encourage you to contact me or one of your site leads, and we can talk a little bit about other options. But the primary recommendation for improving the fit of these masks is the W or M technique, which just involves pre-folding the mask before you don the mask. Of course, each of these steps is preceded by hand hygiene and followed by hand hygiene. So when you remove the mask from the box, of course, fan it out to widen it a bit. With the dark blue side facing outward, you fold the mask and then fold it back on itself to create a W or M shape where the nose piece will be, and then don the mask. Next slide, please. A couple of other suggestions for improving the fit of these masks is to change the way the ear loops are donned. And one of the suggestions you'll see with the image on the left there is to tie a knot at the top of the ear loops. Another suggestion similarly is to tie a knot right at the face at the top of the ear loops, or simply just to twist the ties and create a bit of a tighter fit, keeping the mask on the face a little bit more tightly. Now, if you are using the plastic ear saver pieces, just keep in mind that those are okay for continuous masking, but if you are going into a patient room or involved in patient care, you're of course doffing your mask after these patient encounters. Please do secure it behind your ears, and of course hand hygiene with all of these. If you are using any of these techniques with twisting the loops or knotting the loops to improve the fit, please practice doffing your mask safely and of course with hand hygiene to avoid contaminating yourself. In particular, the X or the twist of the ear loop does require a bit of practice, because when you remove the first ear loop, there is a bit of a tendency for the mask to flip upward, and so just be conscientious of that when you're removing your mask, and practice doffing before you go into a patient room with this technique in place. Next slide, please. I've compiled a number of links. I focused today just on the Vanch masks because our Primagard or Pri-Med masks are in much lower supply across the zone, and we will be moving a bit more to these Vanch masks as AHS's resources have brought these masks in a higher quantity, and there are several weeks of supply of these masks to go through. So like them or not, we need to sort of try some of our techniques for improving the fit, and these masks are considered safe to use. So there are some tips on the website, the link is there, for donning and doffing of these masks, as well as some general information on the AHS PPE homepage, and I've included the link here. I encourage all of you to go through the Contact Droplet PPE learning module. It's brief, it's user-friendly. You can use your iPhone or Android, or you can use your laptop or desktop computer for this link, and it's quite straightforward and informative. And then finally, of course, I would just want to put in a plug for the U of C Emergency Medicine COVID-19 resource page. It is quite up to date with some of the PPE updates as well. And then lastly, I just want to put in a plug for the daily CMO emails, which are now including, and I believe the AHS CEO emails include these as well, include a PPE tip of the day section, which are generally very short bits of helpful PPE tips to keep everybody on track with PPE. Thank you.
So Huma, if you could do the wellness update, that would be great. Thank you.
No worries. Thank you very much, Catherine, Stuart, and Sean. I'm just going to shift gears a little bit with regards to COVID, but from a wellness perspective. We've been getting a lot of excellent information and changes to our practice, and a little bit of insight as to our current status and what things may be looking like in the future. And in addition to receiving all this information, there's us digesting it, and there can be implications for our mental health and wellness in receiving all this information. So I wanted to just take a few minutes, not longer than 5, just to share a little bit of my own experience and some of the literature that's out there with regards to managing this transition. So a few weeks ago, I was sitting in my car in the parking lot at work at South Health Campus, and I was feeling quite anxious about stepping through the doors of the emergency department. What I knew of my South Health Campus emergency department was no more. There was all these new plans. There was the yellow zone, the red zone, everybody's wearing masks. And I was thinking to myself, sitting in my car, was today the day I would walk in and all the COVID patients would be coming in? Was today the day that I was going to be getting COVID? So I sat in my car for about 10 minutes and really psyched myself up to get into work. And finally, I walked into work. And the department looked completely different. People were acting different. There were less smiles. I had difficulty recognizing who was behind these masks. It wasn't the warm and welcoming place I once knew and loved. Things were different in the emergency department, but things were also unsettled and different within me as well. So there was this external aspect of change, the change in the department layout and the way that it functioned, but there was also an internal aspect of transition. And there's in fact quite a bit of literature about this. According to Bridges, who's a leader in change management, the transition is a psychological process that happens from within. It's a direct consequence of all of these external changes. And everyone processes the transition at different speeds and in different ways. But regardless, we're all going through this transition together. And there really is power in naming and normalizing our uncertainties and anxieties. And that's what the Wellness Hub is trying to do. We're trying to help each other and ourselves navigate through this transition zone with our weekly updates and this wellness initiatives. So over the last 2 months, we've left what we knew, and now we're working our way towards an unknown land. An effective analogy, although it may sound a bit silly, is if you can imagine, the Calgary Department of Emergency Medicine, we've all loaded up into a boat, and we've left the land of what we knew, and we're in the middle of this ocean, navigating waters together, not really able to see clearly what the land is going to look like, where we're going to be docking, but we're here, we're together on this boat. What we knew is no more, and we don't really know what the shore is going to look like on the other side. This is both true personally and professionally. So we're sharing very similar anxieties and concerns. For example, financial concerns. Shifts are being canceled, money may be becoming an issue. There's also parenting issues about how to cope with children who are home from school. And we have a lot of anxieties that we share in common. So how do we effectively navigate this transition zone? The key to successfully navigating is supporting each other and sharing with each other. As an example, Ryan Dito shared in a Tuesday newsletter a few weeks ago how to access the financial subsidy from the government. So thank you for that, Ryan. And this is exactly how we successfully navigate these uncertain waters together. I wanted to end off on a somewhat cheesy story that I think really drives home the point with regards to navigating this transition zone. It was a story that was shared recently on Brené Brown's podcast called Unlocking Us. So there's a tale of a person walking into a food hall with wafts of smells of delicious food. There's tables of people sitting down and trying to eat the food, but crying as their bellies were empty and they were starving. They were trying to feed themselves, but they weren't unable to. And looking a little bit more into detail as to what was going on, they all had 6-foot-long spoons that they were using, and they couldn't manage to maneuver the food into their mouths. Now, in the food hall next door, there were tables of people sitting down, laughing and eating, happy with full bellies. They also had 6-foot-long spoons, but they were feeding each other. And that's what we need to do. We need to feed others just as much as we need to be fed. So our mission with the Wellness Hub updates is to help each other through this transition zone of concerns and anxieties. We're going to reach this new land soon enough, but until then, we're in this together, and we're going to continue to support you specifically on the Department of Emergency Medicine. So please reach out, check in, please share with not only your physician colleagues, but also your neighbors and friends. If we could get to the next slide, Erin. A great place to connect with your emergency medicine colleagues is the Slack app, and there's going to be a link to that in our Tuesday newsletter next week. Hopefully you've all received in your mailbox the Department of Emergency Medicine peer support team confidential phone numbers. No problem is too small, so please feel free to reach out to somebody. And lastly, we have arguably the best physician support programs in North America. So please do call the PFSP. They offer a lot of resources, and they specifically can organize professional counseling through video or over the phone. So thank you for listening. And next I'm going to hand it over to Sean Dowling for the Q&A.
All right, thank you, Huma. So first question was addressed by Brian in the Q&A section, but I think it's one to share with everyone. So it's from Mike Betzner. He said that RTs at the PLC have been using a surgical mask on COVID patients and then putting the non-rebreather mask, non-rebreather over top of that. Can anyone talk about this practice, any literature to support it? Brian, do you want to address that?
Yeah, sure. So kind of as I mentioned in the quick chat there, not aware of any literature that supports the location of that surgical mask. There is some post-SARS literature that looks at surgical masks in conjunction with a variety of oxygen delivery devices, so nasal cannula, simple face mask, non-rebreather, etc. From my understanding of that literature, they looked at surgical masks and nasal cannula. It did show that there's a little bit of rebreathing of CO2, which kind of makes sense. That mask is in the way of people exhaling completely. But that if you're at flow rates of greater than 6 liters, then it's pretty much negated. So I just recommend kind of monitoring people a little bit closely if they're on low flow rates with nasal cannula with that surgical mask over top. And then they also looked at the surgical mask placed on top of the simple face mask or non-rebreather, just to show that it didn't change the oxygen delivery or the CO2 component of the respiratory mechanics really at all. So we really have evidence to suggest that a surgical mask on top of those simple devices doesn't change the way that we deliver oxygen. I have no idea where the surgical mask underneath those devices came from. So hopefully that answers your question.
Thanks, Brian. The next question is from Rob Lafreniere, asking early on an early intubation strategy was advocated from the podcast he has been listening to. Placing patients on high volume has been, or intubation early has been discouraged. And what about this happy hypoxic phenotype? Can you comment on this from a local perspective? I guess that's probably best for you as well, Brian.
Yeah, so I mean, I think we're going to try and address this next week with some of the literature from the Scientific Advisory Committee. You know, all we can say is that there was a lot of information coming at us early on that, you know, an early intubation strategy was important. So I think that that's been de-emphasized. But it seems like moving forward, as far as what we're going to be doing, as far as managing some of these hypoxic patients in the emergency department, I think we're going to have to wait for an update from Andrew McRae and collecting some local evidence. Currently, a lot of this is, I think, resource-based as well, and certainly we're not seeing those kind of resource crunches at the moment. Sorry, I missed the whole question. Does that answer things there for you, Sean?
Yeah, I think so. I mean, the question really is around the happy hypoxemic patient, and the experience I think locally is people can correct me if I'm wrong, but in discussions internally, we haven't seen a lot of these patients that have been described on social media with SATs in the 60s, but sitting there texting their friends and looking completely comfortable. The patients we've seen with that profound hypoxia tend to be in some component of respiratory distress or have quite significant tachypnea. So, providing oxygen support and not necessarily moving to intubation solely based on the number, but based on the number and their clinical status as well.
Yeah, and I would agree with that completely.
Next question is from Tahara, talking about buttons on scrub caps. Are they still okay for patient care? Is there concern that this will affect the fit of the mask or contaminates, or any concern about contamination of these ear savers? Maybe that's best for Catherine.
Thanks, Sean. Sorry, I was just typing a response to another question there. As far as I'm aware, yes, they are. However, there have been some issues with the buttons on the scrub caps coming off of the scrub caps, it just related to how they are attached. So if you are using them, just of course fit check them and test them for stability before you go into a room like a isolation room. We wouldn't want to have a mask pop off of the button and have the mask pop off while you're in an isolation room. I'm not sure the concern of whether it's contamination or whether it's stability of the ear savers for going into an isolation room, but the official recommendation from AHS is to only use the ear savers if you are continuously masking.
Great. And the last thing there, it's less questions, it's more comments around the use of the Vanch masks. I think quite clearly there's a lot of concern from everyone around the fit of these masks, the smell of these masks, the propensity for them to lead to some skin irritation, and less than adequate fit. There's been a few comments about different strategies that have been discussed, both the ones that Catherine suggested, as well as Mike recommending this little cloth piece of tape over top of it to help it sit a little bit more securely on the top of your nose. I think Rhonda had a very good point in the comments or in the question section that if you are concerned about this, there's a PPE at ahs.ca email address that you could email your concerns. From what we've heard from Catherine, there's a few more weeks of supply of these masks around. So that will be the mask that we're using over the next couple of weeks. But if you do have concerns, please communicate that with to that email address so that they're aware that the frontline providers are having issues with this.
And I would just add that AHS is very well aware of the issues with these masks. They've received over 1,200 concerns about these masks and sent them back to the manufacturer. So the next shipment, which as I understand arrived 2 days ago, will have some changes to the molding and the fit and the scent of these masks. However, there is also an official product safety reporting avenue with AHS if you have concerns like, a mask popping off or a mask self-contaminating or the fit just does not work for you. I don't have it on hand. I will try to add it to the links, but if you're on shift, you can just ask your charge nurse to direct you to the AHS website for a product safety reporting link, and it's somewhat similar to the RLS reporting link, and they're also collecting data on these masks through those processes. So I do encourage you, if you're having significant issues with these masks, to feed that back. These are reviewed quite regularly.
Great. So there's no further questions at this point, and I think with that in mind, we're going to wrap it up at this point. Stuart, I'll let you discuss this.
Perfect. Thank you, Sean. So thank you for everybody that contributed today. Thank you for joining us for the webinar. And just something that I meant to do up in the simulation is just to thank the Physician Support Fund for their support for the Calgary ED simulation program. We couldn't really be doing what we're doing without your support. So thank you very much. Join us for next week, where the clinical focus is going to be on novel, non-invasive oxygenation strategies and creating new evidence to guide care. That's going to be presented by Andrew McRae, and he'll hopefully be able to address some of the questions that came up today and some of the things we are thinking about, wondering about. And he may have Ken Paha and Jason Weatherall joining him. They are going to be doing a study in Calgary. So join us for next week, and please send us any of your questions. Check the webinar Q&A, and thank you very much. That wraps it up for this week.
One last mention, there's a research day is starting at 11 o'clock. I think most of you will have received the link for that. So thanks to Andrew for that, starting 11 till 12:45 today, also on Zoom.
Excellent. All righty, so thank you very much. Bye-bye.